fetal mortality rates reaching 50%. Dissection can occur throughout the pregnancy, but as I mentioned briefly before, that has occurred in the third trimester, but also in the first 12 weeks postpartum. However, the risk remains increased up to 6 months postpartum. Most often it's type A dissection with the ratio of 3:1 compared to type B, and where type A usually occurs in patients with the aortic dilatation. Type B dissection can also occur in patients without the aortic dilatation. In 3 out of 4 women, dissection in pregnant women is the first presentation of the underlying disease. So the risk factors for the dissection, the most important one is the presence of heritable aortic disease, and this can be either syndromic, so conditions such as Marfan syndrome, Loeys-Dietz, Turner, vascular Ehlers-Danlos, but also non-syndromic heritable thoracic aortic diseases caused by the mutations in genes such as ACTA2, LOX, or MYH11. And there are also congenital heart disease-related aortopathies, such as in patients with the bicuspid aortic valve. Other common risk factors are hypertension, development of the preeclampsia and eclampsia, and importantly, family history of aortic dissection. So in patients with genetic aortopathies attributable either to syndromic or non-syndromic diseases who contemplate a pregnancy, what should happen is genetic counseling before the pregnancy, so to discuss the inheritance of the condition, and in most of the conditions, it's the risk is 50% for the offspring. Also, what should happen is the aortic imaging in the form of echocardiogram, but sometimes it's also MRI or CT scan that might be required, specifically depending on which part of the aorta we are interested in and want to image. That's to determine the aortic diameters before the pregnancy, and therefore to be able to quantify the risk of the pregnancy, and specifically the risk of the aortic dissection. And when we talk about the risk, I put here the table with the most common condition. As you can see, the risk of the aortic dissection varies between 1 and 10%, and the risk is the highest in vascular Ehlers-Danlos patient, in whom we actually advise against the pregnancy, as the risk is substantial. Then the other conditions that it's also the dissection, the risk of dissection is higher is the Loeys-Dietz, Marfan, Turner syndrome, and followed by bicuspid aortic valve, where the risk is the lowest. When we talk about the when we advise against the pregnancy, as in vascular Ehlers-Danlos patient, in all of the patients, and in Marfan and Loeys-Dietz patient, it's the diameter of 45 millimeter when we would say no to the conception, but the diameter at the threshold can be lower, as 40 millimeters in patients with the family history of dissection or sudden death. And this comes from the newly published guidelines this year. And just to highlight, that's what is new, is that in patients with Loeys-Dietz syndrome, we should also advise against a pregnancy and offer prophylactic aortic surgery in patients with this as listed here, 3 mutations as TGFBR1, TGFBR2, and SMAD3. In terms of the management during the pregnancy, so patients with aortopathy should be followed during the pregnancy by a multidisciplinary team, so including cardiologists and maternal medicine specialists. These patients should be counseled to start with about the what the symptoms of the aortic dissections are and what's the immediate action that is required if these symptoms occur, meaning calling RE 999 and saying that you have for instance, Marfan syndrome, and it is very likely that I'm experiencing aortic dissection. All patients with the hypertension should be treated, and the medication of choice is labetalol. Of note, patients with Marfan syndrome should not stay on calcium channel blockers, as there is some data showing that this medication can actually accelerate the growth of the aorta and potentially increase the risk of the dissection. All patients with heritable thoracic aortic diseases, both syndromic and non-syndromic, should stay on the beta blocker during the pregnancy and in the postpartum period. All patients should have surveillance imaging monitoring for both aortic diameters, but also aortic valve function. And the standard test that would happen is the echocardiogram that should happen at least each trimester. But the imaging might be required to be performed more frequently, depending on the aortic diameter and also growth rate of the aorta. If we have to monitor parts of the aorta that are not well visualized on the echo, such as the arch descending abdominal aorta, then the modality of choice would be MRI, and without gadolinium, that should be favored over the CT because of the radiation exposure to the fetus. So when we come to the delivery planning, in terms of the mode of the delivery, all patients that have a chronic aortic dissection, they should have the cesarean delivery. That mode of the delivery should be also seriously considered. Here in the guidelines, again, new guidelines, it's stated that the cesarean delivery is reasonable in patients with the aortic diameter more than 45 millimeters. In those with heritable conditions, with the diameters between 40 and 45 millimeters, again, cesarean delivery might be considered. Patients that have aortic diameter less than 40 millimeter, they can have vaginal delivery. And again, the timing of the delivery will depend on the aortic size and growth rate of the aorta, whether that needs to be expedited or not. As with the other cardiac conditions, in generally, induction should be performed before reaching 14 weeks of the pregnancy. So the last thing is what happens when patients do experience aortic dissection. If it's type A during the first or second trimester, there should be urgent surgery performed with fetal monitoring. If this is, however, the third trimester and type A dissection, first, it should be urgent cesarean delivery followed by the immediate aortic surgery. If that's type B aortic dissection, it's usually medical therapy that is recommended, and endovascular surgical therapy is required only to manage acute complications, but endovascular treatment is usually avoided in patients with heritable conditions. Very rarely we would consider surgery, prophylactic surgery during the pregnancy when there is rapid growth of the aorta. Thank you.
Thanks very much, Justina. That's great. I'm glad you managed to get your slides working again. And I like your picture of Newcastle. Is that what it looks like at the moment? Has it got snow?
Actually, it started snowing today.
Oh no. Okay, so we're going to swiftly move on and see how this next session works. So this is trying to do some cases, a bit of a challenge just to see how different teams work. So I'm hoping James has got a case, which is, I think, one of ours, and then we've got the Newcastle team. So we're going to see how they would deal with things. So I think James is going to present his case first. If you got so William, you're an obstetric anaesthetist, is that correct?
Yes, that's me.
I thought that was. And have you got Ken as well somewhere still?
So.
Yes, excellent, perfect. So, and then we're going to do the same the other way around. So the Newcastle team have got a case, I think, for the Leeds guys. So fire away, James.
Fine, thanks. What I've got a case that's broken down with a few slides. That's hold on a minute, this is not one to share. Okay, we are getting there. So there are various points, Kate. I don't know if you're going to sort of chair this. That
I'll try.
That I've sort of paused.
Yeah.
If you want to pause beforehand,
yeah, okay.
Just tell me.
Pause you. Yeah.
So this is the case. So 37-year-old referred to us in Leeds from another hospital in the region earlier this year. She's a fairly complex background, so she's wheelchair bound because she has a generalized dystonia syndrome for which she had a deep brain simulator implanted in 2003, and she also has sensorineural deafness and can communicate via lip reading. She, from a cardiac point of view, she had an echo in apologies, I'm coming up. In 2019, that the neurosurgeons had organised just before revising her brain stimulator. And that had apparently shown moderate aortic stenosis, but as far as anyone can see, she hadn't had any cardiac follow-up or referral since then. She's got a background of having 2 children. So the first is around 10, was born in her local district general, a section at 34 weeks, and she described being breathless at that point. And then she had a further son a couple of years ago, born at 38 weeks, again in the district general, with a section, and was described as having a panic attack on the way to theatre. So fast forward to the current pregnancy. So this is pregnant from towards the end of 2021. And she has an echo in her local DDH, which describes severe aortic stenosis. She's then referred to another tertiary cardiac centre in the region that's not Leeds at 29 weeks. So this is now earlier this year, complaining of worsening breathlessness and orthopnea. So she's then admitted to that tertiary centre to their obstetric HDU. And I'll mention this again, that's not where the cardiac service is in this city. And she's described as being breathless, talking or moving in bed, with a respiratory rate in her 20s, normal saturations, a normal clear chest x-ray, heart rate of 80, no edema, and a BNP of 112. She has an echo when she's admitted, which describes a left ventricle that doesn't look hypertrophied and has good systolic function. She has an aortic valve, which is described as dysplastic, but probably trileaflet, with a peak velocity of 4.8 meters per second, so equivalent to a peak gradient of 93, mean gradient of 51, and a calculated valve area of 0.6. Mild aortic incompetence, an undilated aorta, and a slightly thickened but normal functioning mitral valve. So I thought I'd probably just pause there if anyone wanted to comment on. And I think this was received, I think, Kate, you received I can't remember. I think you received all of that information on an email.
Something like that.
Yeah.
I think there was conversation.
Oh, there was conversation. Yeah, I
Yeah.
saw an email, but I think you'd had the conversation.
Yeah.
Where it was some, yeah. So I'll let anyone who wants to talk. I'm sort of on. I'll keep it on. I can't really see what's happening.
No, it's difficult, isn't it?
Yeah,
Catherine.
James, a quick question, James. How far pregnant was she?
So at that stage, she was 29 weeks.
29 weeks. Okay. Okay.
I was expecting you to say that she had sort of pulmonary edema and signs of heart failure, given the severity of shortness of breath. So that seems slightly out of context with the echo and the rest of the investigations. She has severe aortic stenosis on her echo.
Yeah.
I guess we're thinking, does she have something wrong with her lungs as a possibility? And she's wheelchair bound and has a sort of neurological illness. Does she have a, we always say, we always go for PE as an option, but I guess in this particular case, perhaps PE might be a diagnosis. So perhaps we might consider a CTPA for her.
Regarding her previous deliveries, were they cesarean section deliveries, did you say?
Yes, they were both sections. I don't think we have any details of why, but there was this description of breathlessness. Well, she said, I presume this came from her, so was said to be breathless in section at 34 weeks back. This was 10 years ago. And then she got quite far on at this second one, 38 weeks.
James, and was she, sorry to interrupt.
No, go.
Yeah, was she on any medication at this stage already, like beta blocker or diuretic therapy?
At this stage, I don't think she is. No, she's just admitted fresh.
Okay, yeah, and clinical wise as well, because I agree with Ken that having the rather low BNP, the clear chest X-ray, was she clinically in pulmonary edema?
No, I don't think she was. No.
Yeah, I think I would also like see if there's any further tests that need to be done to check if there's no other cause of the shortness of breath. But obviously we are a bit concerned because the velocity is 4.8. It's almost 5 meters per second, so which is severe, almost critical. So she could decompensate as well any moment basically. But yeah, I think potentially maybe do further investigations, CT.
Okay.
Were you still testing for COVID back in early 2022?
I presume she'd have had a COVID test as a routine being admitted. At that stage, she would have done, yeah.
She did.
Yeah. Oh, I'm not going to say anything more at the moment, but yeah. She did have a routine COVID test. It was negative. But COVID slightly comes into it later. Not that she had.
Yeah. Right, move on, James, because we'll use a bit of time up.
So, okay, while she's in this tertiary centre, then there's thoughts about, as you mentioned, Ken, she's clearly got this dystonia. She's quite cramped, so he just wonders whether some of the muscle issues, the cramped posture, could be contributors to the breathlessness, rather than necessarily the heart. They did give her some diuretic, and she apparently felt a little bit better for that. They were particularly concerned about a limited cardiac reserve, and felt that she may not be far from frank pulmonary edema, but difficult to judge because of her complex other medical issues. And they made a provisional plan locally in this other centre for an elective section under GA at 34 weeks in cardiac theatre with surgical cover. But that is notably in a different hospital to where the obstetric service is and the neonatal service is in this city. So I suppose any particular thoughts on that as a plan?
Is the brain stimulator, is that causing any issues with raised intracranial pressure? Is regional anaesthesia contraindicated by the neurosurgeons, or was GA?
I'm not aware that it's causing. I don't think it is causing any problems neurologically at all, and I don't think it's a contraindication to regional anaesthesia either.
I mean, it seems like the plan to have it under GA is more to do with just the comfort of the cardiac anaesthetist, which is understandable, rather than for an obstetric reason.
Yes, I think that's yes, I think that's probably fair.
I think, James, at this stage, I would, and I guess the team there has kept her in as an inpatient. So I would definitely keep her in as an inpatient monitor, and indeed try to, if she remains stable, try to push the delivery a bit further down to 34 or 36 weeks, but definitely keep her in a cardiac ward. I would continue with low dose of diuretics probably, and definitely put her on beta blockers, which might help a bit the filling, of course, and the output. Yeah, and then see how she goes, and have indeed a surgical standby. If she were to fully decompensate, then to go for a planned delivery, C-section, and then see, obviously, then still monitor her, because she might not need surgery, of course, once she delivered the baby, although she is facing surgery soonish.
Yeah. Okay. Thanks, Catherine. So there was some neurology input, just to add to that. So they just mentioned they've been thinking about some botulinum toxin to her right arm after pregnancy because of some spasm, meaning she was finding it challenging to use her wheelchair. She had an ABG and had a respiratory alkalosis. They wondered whether she was just anxious on a ward or whether that was in some way a contribution from the dystonia. They went back to the literature and looked at respiratory symptoms in dystonia. And there wasn't a lot there, but apparently that's usually due to laryngeal dystonia, which isn't something that she was thought to be affected by, or potentially just related to abnormal chest wall movements and diaphragm movements. They suggested some spirometry, although apparently the local respiratory team didn't think that was necessarily worth doing. But they said that there was no specific treatment for the dystonia during the pregnancy. What did actually happen was that she was transferred, you could probably guess really, because otherwise we wouldn't be presenting it, she was transferred to Leeds within a couple of weeks as an inpatient at 31 weeks. Really, partly because we just have the advantage of having the cardiac service, the obstetrics and neonates all on one site. When she was assessed in Leeds, clinically, she didn't look like she was clinically in any form of cardiac decompensation. BNP at this stage was less than 35. The COVID thing was that she did remain negative, but her husband and 2 sons were COVID positive, and she did have some spirometry, which you can see there, FEV1 61% predicted and an FVC of 58% predicted. So a restricted type pattern, as presumably one would expect. And I'm not going to show you the echo pictures, but we repeated the echo and she had a heavily calcified aortic valve with a peak velocity of 4.6 meters per second. We felt mild LVH, but normal systolic function. So we're now 31 weeks, not much different. Any kind of further comment on the next step at this stage? Keep her in still?
I would personally keep her in, although again, cardiac-wise, things look reassuring. But with that degree or that level of aortic stenosis, I would be very cautious. But again, the NT-proBNP or the BNP is very reassuring. But I think I would just keep her in. She's not far off the delivery, and she might decompensate from a respiratory viewpoint and need urgent readmission. That would be my feeling.
Any other thoughts on that from anyone else?
To get vaccinated for COVID?
Sorry, I missed that.
Sorry, was she vaccinated for COVID?
That I don't know off the top of my head. I don't know if you do, Kate.
I can't remember. The other thing I can remember about COVID and hers, because she was partially, she was hearing impaired. We had to use those clear masks because she lip read. It was really difficult communication.
I mean, sending her home with 2 people at home with COVID in her particular condition probably isn't a good idea. I think I agree with Catherine. I would keep her in for the time being anyway. I mean, she's got severe aortic stenosis and this neurological condition. I mean, she's pretty high risk if she gets kind of an infection, or pretty high risk in terms of deterioration. You're going to want to deliver her pretty quickly, I would have thought.
So we did keep her in mainly for that reason, for the not wanting to send her home until her family had fully recovered and were negative for COVID. But we then did let her go home on some prophylactic low molecular heparin, as you mentioned, Catherine, a small dose of continued diuretic and a small dose of diuretic of beta blocker, bisoprolol. That's the other drug there is an antispasmodic. And we took advantage. She had a tooth extracted while she was with us as well. And then a provisional plan was made for a section with tubal ligation at 37 weeks, but the mode of anaesthesia at that stage hadn't been decided. Previously, she had struggled to lie flat, I think, during this kind of episode, but certainly with an elective admission to the cardiac intensive care unit. I'm sort of almost asking the same questions here, right? But does anyone want to argue differently to that? I know it's slightly different to what you might have done. I'll take that as a no. Or as a reason, or possibly a yes. But then we then saw her at 36 weeks. She was relatively well. I think that's when I first met her. And at that point, she expressed a desire to be awake during elective section. And in fact, that was the plan that was then made. And she did undergo an elective section shortly afterwards with tubal ligation, awake with the CSE, monitored with an art line, ended up going to ICU electively for 24 hours, but didn't misbehave, and was on a phenylephrine infusion, coming out of the section into ICU, which was weaned. And then a few weeks later, she was well in clinic. Peak velocity, just as she's lost some of that increased cardiac output, had gone down slightly. It was 4.1 meters per second. LV function looked good, and she was doing very well. And that's the latest I know about her. I think she's now on a kind of 6-monthly review. I didn't see her much during the admission, so Kate, if you want to add anything to it, to any of them.
So just there were a couple of things. The deep brain stimulator meant that her ECG was totally uninterpretable. So if you were looking for strain, you have no chance. And if you turn off the deep brain stimulator, she immediately got loads of spasm. So you could only really do that when she was under GA. And there was an issue about the deep brain stimulator and diathermy, which had to be all looked at pre-section as well. And then the only other thing to say is that we were really super popular with intensive care, because normally we give them really disastrous things, and then we sent this nice lady with a newborn baby, and they were all really happy because the baby, she was awake, she wasn't ventilated, she was absolutely fine, and they were all very happy to see the new baby. So that was a good end to the story. But yes, it was definitely a challenging one. And it was really difficult to tease out whether it was all cardiac or whether it was really other issues rather than the cardiac disease that were causing the symptoms. But yeah, she was really interesting. Good, thank you. Right, so we're going to turn. Have you guys got anything to feedback to us on that case? Anything that you think?
Yeah, maybe. Yeah, I think it's very well managed, because you could either jump on it and say send this lady for urgent surgery because you think she's got a velocity of 4.8, but indeed the follow-up echo, indeed, it's volume driven.
Yeah.
So yeah, I think it's very well managed, and like staying calm, doing the investigations that are needed, that help with taking the next decision. So yeah, very nice case.
Right.
And although it's complicated, the deep brain stimulator, I mean, I think our experience shows that as long as someone is not actually decompensated from a cardiac point of view, a CSE is a very safe technique.
Yes.
It doesn't increase the cardiac output. In most cases, it will improve cardiac function. And people, even if they've got a respiratory cause, which makes it awkward to lie flat, they usually tolerate it very well. So
yeah, definitely.
Yeah,
okay.
I think it's good that you held your nerve as well to sort of 37 weeks. There's always a temptation with these kind of patients I mean, the plan in the hospitals to deliver at 34 weeks for not necessarily good reasons, and there's always sometimes a bit of pressure to get these patients just deliver them. That will solve the problem, but that's not necessarily good for the baby or for her either. So I think that's right that you kind of took a step back and reevaluated the whole thing, and then I think it's reasonable to get it to 37 weeks. That was very good.
Great. So we're going to turn the tables, and Thomas is one of the obstetricians in Leeds. I think Kuldeepa is going to present the case that the Newcastle team have looked after, and I think that Tiff Halsey, who is one of our obstetric anaesthetists who runs a cardiac clinic with us, is also on the call. Yes, she is. She's got a very smashing hat on. And I think we've got Alex Sims is also here as well from our side. So I'll shut up.
Thank you.
So
can you see my screen there?
Yes, yeah.
That's great, thank you. So, hi everyone, my name is Deep. I'm one of the ACHD trainees in Newcastle. So today I'm going to present a patient who we recently looked after on our unit. Essentially, she's a 20-year-old female who was gravida 2 para 1 with known Marfan syndrome, which was diagnosed on genetic testing at birth. She was positive for the FBN1 gene mutation. She had a positive family history of aortic dissection. Unfortunately, her father had had an aortic dissection at the age of 27, which was repaired, but he subsequently died from a re-rupture at the age of 42. So there were a number of challenges in this patient. Sorry, my slides aren't really moving there. Here we go. So she had been essentially under cardiology follow-up in Scotland for most of her life, and she had only just moved from Dundee to Newcastle. And she was actually referred to us when she was 33 weeks gestation by a community midwife. And up until that point, most of her antenatal care had been in Scotland, and essentially she came to us with very little information from a previous hospital. We didn't have any paper notes or any electronic records of what had happened since. And also she was actually 3 days prior to the clinic appointment, she ran to cancel, and we had to call her from clinic to persuade her to come. So quite challenging in terms of getting previous information, but also persuading her to come to our clinic appointment when she was 33 weeks pregnant. She had had a previous normal vaginal delivery at the age of 16, following an unplanned pregnancy in March 2018. Previously, she was taking Atenolol 25 milligrams and Losartan 12.5 milligrams, but when we saw her, she wasn't on any medications. So from her previous notes, I found out that her aortic root dimensions previously had been fairly stable from 2011 to 2014, with a sinus of Valsalva measuring 27 to 28 millimeters and an ascending aorta of 22 to 24. But you can see from 2015 to 2018 that there had been progression in the measurements, particularly on the sinuses of Valsalva. Unfortunately, I didn't have any information about her aortic root dimensions between 2018 to 2021, as she had DNA'd her clinic appointments back in Dundee. But when we saw her in clinic, she had a BMI of 20, her blood pressure was 129/84, her heart sounds were normal, and otherwise examination was normal. And our clinic transthoracic echocardiogram showed that her aorta was now more dilated. She had a borderline low LV systolic function, ejection fraction of 50%, and she had a trileaflet aortic valve with no significant aortic regurgitation. And these are her echo pictures. Essentially, you can see that sinuses were now 4.3 centimeter, which is a significant progression from before. The STJ was 3.2, and the ascending aorta proximally was 2.9 centimeter. The arch was fine with no evidence of coarctation on color Doppler. So in summary, this is a 20-year-old lady who's known to have Marfan's, a positive family history of dissection, who's presented, at 33 weeks gestation and blood pressure of 129/84 and progressive aortic root dilatation. So at this point in time, would you consider doing a 24-hour blood pressure monitor? Would you recommend home blood pressure monitor? Would you start any hypertensives, and which one and what would be your target blood pressure? And is there any other investigations that you would recommend at this point in time?
James, Alex.
I mean, she's not on a beta blocker, is she?
No, she wasn't taking any currently when we saw her.
Her heart rate's okay, is it?
Yes, so her heart rate was just, normal range, yeah.
And I think probably personally the first thing I'd probably do is establish her on a beta blocker. Anyway, you might want to get some cross-sectional imaging, so a non-contrast MRI potentially would be helpful. I think at 43, you're getting close to needing to do something, aren't we here? With 33 weeks in as well. I think we'd have to get. I'd be probably requesting urgent MRI to get a bit more information about what's going on in that aorta. The problem is we don't know where that is, do we, in the timeline? Because 2018 was the last measurements, and then she's rocked up with a bigger aorta, but we don't know whether she was like that pre-pregnancy or that's expanded within pregnancy. But she certainly needs to be back on a beta blocker MRI and then review and see what she's doing. I presume she's not got any concerning symptoms, chest pain.
Not at that point in time, no. Yeah.
And obviously counsel her on that as well.
I would consider maybe keeping her in for a short while, given her compliance is really poor. Trying to get her established on her antihypertensives, given that she's stopped taking them and then is not really engaging very well with the services. I'm not sure whether she would stay in, but maybe, getting the investigations as an inpatient and trying to get her well established on some decent treatment for her blood pressure as well, I suppose. And go from there, I suppose.
Was she on the beta blocker and the ARB for prophylaxis rather than blood pressure treatment? Do we know? Prior, you might have presented the blood pressures, or I missed it.
No, so this was a first presentation to us, and unfortunately we didn't have any information from prior, but it sounds like she had been started on it, prior to her previous pregnancy when I looked back at the letters, and then she'd either stopped taking them or they were not reviewed because she had DNA'd her appointments between 2018 to 2021 essentially, and it was kind of knocked off her repeat prescriptions.
But yeah, most likely it was prophylaxis.
I think we also need to discuss mode of delivery with her as well. She's had a normal delivery previously, and we're going to need to pick up that discussion of how she delivers fairly soon and what her opinions are, because they may well differ from what the obstetricians and cardiologists and the anaesthetists' opinions of how her delivery is going to be. So picking up that conversation, because you've probably only got a few weeks left to have that, I think is important, as well as from the obstetric side, reiterating what we've heard already about the safety of the beta blockers, which one suspects she stopped in pregnancy off her own bat.
Okay, any more? So we're probably
second that, and I would do think I wouldn't worry about blood pressure monitors. I would have thought admission so that you can institute and up titrate beta blocker to a maximum kind of tolerated dose. Inpatient MRI. You want to know what a descending, the one that dissection I've seen during pregnancy was a descending aortic, it was a type B dissection, so you need to know the whole of the aortic arch.
Yeah. Okay.
So our thoughts were, this lady had multiple risk factors for dissection, including a positive, family history of dissection in context of Marfan syndrome and a dilated aorta. So we requested an urgent cardiac MRI, and we discussed with her that, based on the data that we had at that point in time, she was a higher risk for vaginal delivery, as Justina presented previously, with the ESC guidelines, aorta more than 40 millimeter being a contraindication for vaginal delivery. So she, we started her on bisoprolol 1.25 milligrams once a day, aiming for the blood pressure less than 120/80. And we also arranged for serial growth scans and an anesthetic review at that point. And most importantly, she was safety netted. So I've just taken this screenshot of a paragraph from the clinic letter. So we explain exactly about the symptoms of aortic dissection, which included severe chest or abdominal pain. And should she get this, then she should immediately phone 999 and attend hospital. And sort of, through our letter, we were trying and give instructions both to the A&E doctor that she will need cross-sectional imaging and senior review, but also to the patient what to do exactly in this situation. And we also said if she had any concerns at that point in time to contact us, if she were to develop any concerning symptoms. So, this is, Justine has already gone through this, but essentially, we sort of talked about this, about the risk of dissection. If the aorta is less than 4 centimetre, there's 1% risk, but if it's more than 4 centimetre, then, 10%, which is quite high, 1 in 10. She had an MRI heart very soon, 4 or 5 days after we saw her when she was 34 weeks. And this confirmed a mildly impaired LV, ejection fraction of 47%. The aortic valve was okay, tricuspid, no regurgitation. And this was her aortic dimensions. Essentially, the sinuses were 39 by 38 by 40. The STJ was 33 by 29, and the ascending aorta was 23 by 25. The descending aorta and the arch were fine. So in terms of this new MRI data, in terms of delivery, what will be your thoughts about the method of delivery now, vaginal delivery versus a C-section, and what would be the ideal timing of delivery in this situation? So I'd love to hear your thoughts.
How are we a week down the line or 2 or 3 weeks down the line at this stage? 34
yes,
weeks.
Yeah, 34
so we're just
weeks,
a week
yeah.
down the line.
Mm-hmm.
I mean, I think, and I'm sure Kate and James or Alex will take over, you have to appreciate the difference in the measurement in the modalities. And I would be cautious about being reassured personally about a vaginal delivery, given the measurements, I think, if I'm reading my screen correctly, are less than they are on echo. I think you've got someone with a progressive dilatation who is at the upper end or above the limit for vaginal delivery, on top of someone with a family history of death from dissection, which in itself puts her into the high risk category. And whilst my team will be surprised to hear me say this, I think a cesarean would be the right way forward, though I do bear in mind what we saw earlier about that cardiac output in the postpartum period as well. And a close postnatal plan needs to be put in place, because however you have this baby, that auto transfusion plays a significant part in this.
It's really difficult, isn't it? The absence of serial measurements of her aorta, seeing her as a de novo patient without accurate measurements in the run-up, you've no idea what you're playing with, really. But I think I'd be vaguely reassured by that. But there does seem to be an increasing measurements, and I'd watch it like a hawk, but with a plan to probably keep going and then either a section or think about low cardiac output delivery if you've got no change in those dimensions as you scan it. But I'd probably be seeing her weekly.
I would say I agree with Kate. It's a difficult one. Now, Tom will be surprised because I'm normally pushing for caesarean sections on anybody with a bad heart. We have these conversations quite regularly. She's had a previous normal vaginal delivery. It's really hard. I think you could choose either, actually, and there would be benefits and risks on both. So I think we would just have to keep a very close eye on her and then make a judgment nearer the time, maybe with, I don't know, additional imaging perhaps nearer. If she stays well, doesn't report any chest pain, everything else is okay, maybe an epidural and a low pressure delivery might be okay. I don't know. I would probably, I don't know, I'm kind of doing that.
I think usually, usually, and we know this, that women that come through like this have an idea in their head of what they want to do and of where they're going with this. And I think this, right to the beginning of the story, it's about the holistic view. What were hopes and fears? She became pregnant, she disengaged with care, and all of that stuff going on. And I think in this particular situation, I'd agree with Tiff, it's monitoring, but her hopes and dreams and everything will fine tune themselves for her to make the decision about how she wants to proceed. And I have to say, I agree with the general sway that probably if it was me saying to her, what do I think, it would be a C-section, because we know at Leeds we've had experiences before with dilated aortas, etc. And ultimately, yes, we want to give the woman a choice, and we don't want to give a false choice, but we want to give her a choice and say, look, we have safety nets, etc. But I would say in this particular situation, it's what she wants, but also, what we feel is the safest thing, and then discussion around that.
Sarah, you've taken the words out of my mouth. I think putting her views in is absolutely key here.
So Ken and Alex wanted to come in, but I didn't see what order you came in on. So Ken.
Yeah, I mean, I really struggled with this patient. So I was the one counselling her. So initially, when we saw her initially at 33 weeks with that echo, with that family history and everything else, and the echo measurement of 43 millimeters, I was counselling, I was saying to her, yeah, I think you're going to need to have a cesarean section. We will be worried about your aorta and dissection. And that came as a really big shock to her. She wasn't expecting us to say that. In fact, I mean, she's sort of almost skipped through pregnancy somehow, avoiding all of these issues, I think. And there were sort of some sort of child protection issues that meant she kept on going back to Dundee and was really very difficult to get hold of. And we had to sort of almost drag her into the clinic. So initially, when I saw her with that echo, I counselled her much more towards having a planned elective cesarean section. And then when we got the MRI, I was a bit more reassured, and I was thinking, oh no, she has had, a normal vaginal delivery in the past, possibly, a vaginal delivery with an epidural and good pain relief, limited second stage might be a possibility. But when I put that to her, I'd actually frightened her so much with the first consultation that she was sort of scared to have a vaginal delivery, and so she chose to have a planned cesarean section. So almost the decision was taken out of my hands. But yeah, I think from what everyone's saying, those kind of issues all played together to kind of make it quite a difficult consultation, actually.
And Alex?
Yeah, I have a similar issue with Tom here in terms of the echo is telling us that the aorta is much more than the MRI is, and firstly, and I probably should know this, I'm not sure what the data that the ESC guidance and echo, I presume it would be echo because MRI hasn't been around that long, and it's a bit like LV ejection fraction. So if your echo data is meeting criteria, then maybe we shouldn't be so reassured in MRI criteria. And equally, why is our LV ejection fraction down?
Okay.
That's
Justina, did you want to come in? I'm aware we've got 7 minutes left, gang.
Yes, quickly. So with I think retrospectively, and now what's my approach to the CT and MRI is also that I ask for the maximum dimension. I ask for all the measurement cusp to cusp and cusp to sinuses. This is in fact the cusp to commissure, so might have been 1 or 2 millimeters underestimated, and I think that's the solution, Alex, to the measurements, that the echo is will be probably more the dimensions will be more close one to each other if we measure that cusp to cusp on the cross-sectional imaging. And with the ejection fraction, I believe that she has a degree of the cardiomyopathy that we sometimes see in the Marfan patients, that they do have sometimes impaired ventricular function, and that's due to genetic impact on the myocytes.
Okay, so should we move on in the timeline?
Yeah. So she had an elective C-section, which was maternal choice at 38 plus 3. There were no immediate complications. She started breastfeeding and she was discharged from on prophylactic tenzaparin. And again, more safety netting at that point in time. But unfortunately, day 5 postpartum, she was seen urgently in ED with a sudden onset severe chest pain relating to her neck and abdomen. There was actually surprisingly no difference in blood pressure in her right and left arm. And she had an urgent CT aorta, which showed a small dissection flap, which was originating close to the left coronary cusp and extending across the aortic root into a very proximal ascending thoracic aorta, which you can see under cross-sectional imaging here with a false lumen. So she had urgent cardiothoracic review that night, and emergency surgery was discussed with a 5% mortality risk quoted. She was transferred urgently to cardiac ITU, and a TOE, which was performed then, showed moderate aortic regurgitation, and a dissection flap was visible in the root. So for this patient, if we think about the ideal surgical management, and obviously she needs to have a root done, but in terms of the aortic valve being regurgitant, there's decisions to be made about whether you should have a metallic valve, should have a tissue valve, should they have a homograft.
Tom?
So I'm just going to take this back a step. Valve choice is well beyond my remit. Firstly, I think it just highlights that you're damned if you do and you're damned if you don't sometimes in these cases. If we had opted for vaginal delivery under an epidural, people would have muttered about cesareans when she'd come back in 5 days later. I wonder, was she kept in, or did she discharge herself before 5 days, just out of interest?
I think she was just discharged, Tom. Yeah.
Okay. I mean, we would, I think, normally keep our women in for around 5 days here.
Well, we try, don't we? But
we try, but many get bored and walk out. Indeed,
to be fair,
exactly.
Because it's so horrible to.
Yeah.
And that's.
But on the flip side of that, James has looked at our dissections and found, I think, vast majority of ours to be after 7 days. Is that right, James?
Yeah, I think we usually discharged by day 5, and I think if you look at the kind of dissections postpartum, then you probably need to keep them in for 10 days if you're going to be fairly sure about them being in hospital when they dissect. Most of them are a little bit beyond the 5.
And no one would tolerate that.
There's no way this
so it's a kind of compromised position that we take, isn't it?
Yeah, and the data even shows that it's really 12 weeks, so it's difficult, but maybe it does make sense to keep them a bit longer.
I think in terms of the valve choice, I think we'd be looking to see whether there is any possibility of doing a valve sparing, and otherwise it's a bit tricky, isn't it? She's got 2 children, but she's only 20.
Mm-hmm.
I think she'd probably end up coming out of theatre with a mechanical valve and root prosthesis, if I'm honest. But there'd be an argument to think about.
I think also with the homograft, obviously we don't have it on the shelf, so that's the problem with the homograft. So it will either be tissue or mechanical. But I agree, Kate, that here there might still be an option in a valve sparing, which would be the best, of course, in her case.
Yeah.
Did you say she had AI?
Yeah, she had moderate on the TOE.
Mm-hmm. Yeah, I mean, I suspect you probably do need to replace the valve, don't you, in that setting, rather than. I mean, this will be her first stenotomy, wouldn't it? So
could potentially go tissue valve.
And decision making in that acute situation is rather difficult, and she's not been great at complying in the past, and she's only got 2 children, so. I don't know, my hunch is I'd be aiming for a tissue valve, knowing I might need to do it again in a few years, and then after we've spoken to her properly about other things, but I don't know.
Yeah, but I still think she'll come out of theatre with a mechanical conduit.
Well, she could have. We've done a few tissue valves with vascular grafts on top, haven't we?
I know, but in an acute dissection, in a immediately postpartum woman, the surgeon's going to want to get in and out, aren't they? Not put a biological valve within a graft and.
Yeah, maybe. Yeah, I don't know how quickly they can sew it.
Yeah. So what happened?
So as you said, Kate, so she came out of theatre with a modified Bentall and with an Onyx valve, which is mechanical, and a synthetic tube conduit, which was 26mm. So this is the recommendations in emergency surgery. Essentially, the procedure of choice is a repair with a composite graft, and ideally we're trying to preserve the aortic valve or replace it with a homograft to avoid the need for long-term anticoagulation. But I think for her, and this was in the middle of the night with an acute dissection, someone who was extremely unstable, I think they just had to go and do the procedure that they thought would be life-saving for her. The post-op echo, essentially, as you can see, show that a mechanical valve is well seated, and there was no significant paravalvular regurgitation. The aortic root now measured 2.4 centimetre. So she stayed in ITU for a couple of days and then was discharged to the cardiothoracic. So this is a normal post-op cardiothoracic ward, and there were still a number of issues that we needed to address at that point in time, and it was really important to involve a multidisciplinary team to help us with all of these issues. So first of all, anticoagulation and medication review, especially given she was breastfeeding. There were also issues around breastfeeding itself. So baby was with a partner at home and she wanted to continue expressing and breastfeeding, a lot of issues with breast engorgement and mastitis. So, getting that support for her was really important as well. And I'll talk about how we did that. Obviously, contraception and trying to establish contraception prior to discharge was one of our main aims. And also we found out at that point in time that she had previous child protection issues with regards to her first child. There had been some previous safeguarding concerns, but because of the lack of documentation and correspondence when previously, we kind of were made aware about this at this point in time. So I'm just going to spend a bit of time talking about the wider MDT approach, which kind of really helped in the post-op care. So first of all, she had a medications review by the obstetric consultant, supported by the ward pharmacist, and essentially all of the post-op medications were reviewed, and none of them were contraindicated in breastfeeding. There was some education around the potential effects of morphine and what the family should be told to look out for. We reassured her that warfarin was safe in breastfeeding, and there was this useful resource that we kind of left for the surgical nurse practitioners and the surgical junior doctors to double check any medications, against this, this resource, that they could double check, if they had any concerns and needed to give her analgesia or antiemetics post-op. She had a joint cardiology obstetric review prior to discharge, and we discussed a number of issues, including the fact that we would strongly discourage her from any future pregnancies due to risk of further dissections, but also due to the teratogenic effects of warfarin. And we also advised that if she was adamant that if she wanted another pregnancy in the future, that she needed pre-pregnancy counselling, and that she couldn't stop her warfarin without consultation with us due to risk of valve thrombosis and so on. The other really important thing was that our consultant midwife, Claire, had quite a lot of input with her in the surgical ward, not just with the patient, but also with the nursing staff. A lot of discussions about how we can support lactation, how to look out for signs and symptoms of mastitis, how we can observe her C-section scar and postnatal emotional support. And we also liaised with PICU and the children cardiac department with regards to what facilities there were for her to express milk and to store breast milk, and how she could still deliver breast milk to a baby who was at home with a partner. So there's quite a lot of support there, which was really useful. In terms of contraception, this was really quite challenging in this situation. So we discussed a number of times that reliable contraception was essential. So I just wanted to hear your thoughts as to, which ones would you discuss, which one do you recommend in someone like her?
What Thomas just said, it's coiling at section. Get a coil-in. I mean, I would agree with that. I think you've got an opportunity. She's too young to have a tubal tie, and I'd put a coil in at section. My personal view, though, sometimes is coils at section can be a bit tricky, migrating threads and migrating coils, etc. But I think for her, that's probably the best way of doing it, obviously with her consent. The implant is fine as well. I think that's another option if she doesn't want to have something in a uterus. But I agree with Tom. I think coil at section, because it's reversible and it's reliable. She doesn't have to remember to take it, and it's I don't know what other people think.
Yeah, just in the interest of time.
Yeah.
Do you want to let us know what you did?
Yeah, so we essentially discussed long-acting reversible contraception and offered Nexplan and Mirena Col, but she declined. We then offered Depot in the form of Nasania Prest, which is a subcut injection rather than IM due to a risk of anticoagulation and hematomas. But again, she declined, and that's the last minute. And despite our best efforts, essentially she left without contraception because she would decline at the last minute. Whatever was offered to her. But what we did is we referred her to the sexual health clinic, with the hope that she would attend. And with regards to the previous child protection issues, again, I already mentioned my difficulty with with access from previous records, but we wondered whether some of the concordance issues may be linked to her to a previous experience and to these previous safeguarding. And essentially she was discharged with 3 follow-up appointments, one with the community warfarin clinic, and we arranged a very soonish appointment to the joint cardio obstetric clinic and a sexual health clinic appointment. So just a few take-home messages from this case is, you know, as Justina mentioned, postpartum aortic dissection is rare but a lethal complication. Extremely important to diagnose promptly and treat in a timely fashion. And in young women such as herself, consider long-term issues with anticoagulation, contraception, breastfeeding in future pregnancies. And I think this case really highlights the importance of the wider MDT and a joint cardio-obstetric input. So that was all my slides. Thank you.
Oh, thanks very much. That's a great case and beautifully presented, if I say so. I think so. That brings us to the end of the day. We're only 5 minutes over, which is pretty good. I think just a couple of things. The first is it's great to. I know that doing this online is never as good as doing it face to face, but it does allow us to reach more people. So. Most of the day we've had about 80 people on this training session, and I think if we did it face to face we'd never get that many people, and half of the northeast would be stuck in the snow as well, so that would have been a bit of a difficulty. I think the other thing that this highlights is the fact that this is definitely a team sport. So you know, if you look across the people that we've had today, cardiology, obstetrics, anaesthetics, and we take lots of advice from lots of different people. So definitely one to you know, a team management, do it with your friends rather than trying to go it alone. And also massive thanks to Terry, who is the network manager in the Northeast, who's set up all the Eventbrite and managed all the registrations. And thanks to all the speakers for giving up their time. There is an online form for feedback, and you'll get which I hope Terry has put in the chat, or it's going to come out through Eventbrite. There'll be a link to the feedback form, so if you can feedback for us, give us any ideas about what you want to do for another session, and you'll get a certificate of attendance. So thank you very much to everybody for attending. Thanks to all the speakers.
Thank you very much, Kate.
It's a pleasure.
Yeah,
Nice
thanks,
to,
Kate.
it's nice to see you all. I know
Thanks,
we're not really
Kate.
actually seeing you, but to see you all virtually.
Thanks, everyone. It went really well. Great timing.
I like the Christmas
Thanks,
card, Terry.
It's not real. Yeah, I don't have that on my back on, thankfully.
Yeah. I'm just looking at.
Okay.
See you later.
See you all. Bye-bye. Bye.
Bye. Thank you.
Thought it went well, Terry, didn't you?
It went really well, considering just how many different elements there were, and I thought the presenters were great. Like I said, to keep them to time, that was really good.
Yeah, I think the content was great as well. Don't you think it flowed really well?
It did. Yeah, it was well linked. I think it was really great having the second half of the afternoon being able to juggle around. I think was really useful. Someone's always going to have an issue with sharing
with the IT. I like the cases. I like the cases at the end.
Yeah, no, it was good.
Yeah, I like that actually. I'm sitting here thinking, oh, I really want to do another session where we do something like that. I think it's so valuable.
Yeah. Oh, I'm sorry. Onto my screen.
Dropped your screen.
Yeah, I just crossed my leg. Because I've had to come in the front room because it's so cold in the kitchen.
I was going to say, Alison, what are you doing without any heating? That's awful.
Well, my mum only lives around the corner.
Oh, right.
It's the biggest thing is the water. There's no hot water.
Oh,
you can't shower, can you?
Have you not got an immersion heater?
No.
Oh, God.
So my mum only lives around the corner, so I'm going to go around there in a minute for a warm and a shower, and maybe my tea if she's feeling generous.
And your tea. So you're washing around as well, Alison.
Oh, we've just had all that. My sister's had her doing all the washing. She is 89, my mother. I don't think she should be doing everybody's washing.
I know she's looking after you lot at 89.
She's great, my mother. Yeah. Yeah. So it's very
Excellent.
good. We
Very
should
good.
try and think of something else to do together, shouldn't we? I don't
I
know.
think so, yeah, because I mean, what we've tried with our, we really want to have a clinical session where you do that case presentation, and then I think the panel side of it's really, really good as well.
Yeah, I like that.
So maybe we should do, yeah, do a half day where we do something like that, even between the two networks. I think could be valuable.
You know, because doesn't it say something in the standards about peer review of decision making or something like that, Kate? I think it does say something.
There is. We were trying to set that up as a joint MDT thing. I wonder as well whether we should, if we're going to do something joint, we should try and bring the Liverpool team on as well.
I was thinking that actually when we were talking. Yeah,
it's then across the north of England, isn't it?
Yeah, I think we should.
Yeah,
Raphael's got a role now, hasn't he, as the national advisor?
Yeah.
Has he?
Yeah, he was on one of the calls. It was mortifyingly embarrassing, Kate, because he says, "Oh, I know Alison. She taught me everything I know about looking after patients in PICU." And I was like, "Oh, thanks, Raph." I thought, God, that first of all, that tells everybody how old I am. Because he didn't look that young. Anyway. It would be good. There is a new manager, isn't there, at the moment in the Northwest? Because they haven't had a manager really for a long time, and she's quite proactive. So I think we could set something up.
She would. Yeah, I think she'd be keen. Yeah, I'll drop her. Yeah, I'll drop an email after this, and then we'll just, because it did go really well. So I think the northern kind of thing would be great.
We just have to think about what we want to do. That's all.
Yeah.
And wait for feedback and see whether everyone else.
We could wait for feedback, couldn't we, and see what else.
Yeah, see what people.
Yeah.
It's a slightly different
see what education people are after.
Yeah. But I thought that went great. It was really good.
Great. Thank you very much.
Yeah, see you later.
Excellent. Happy Christmas if I don't see you.
Oh yeah, and you. Happy Christmas, everybody. See you later. Bye.
Bye.